You're listening to the Physio Matters podcast this month in association with Firefly, orthoses, and this is session 18. Welcome back to the Physio Matters podcast for session 18. I'm afraid I'm still your host, but I assure you that the rest of the team are getting closer to the microphone, so prepare yourself for some new interviewers. But until then, I'm still Jack Chew, and I'm here to grill today's expert on a clinical topic with the usual balance of critical reflecting on traditions, whilst championing contemporary evidence-informed reasoning. Huge thanks to all those tweeting, emailing and Facebook posting feedback for session 17. It seems that Paula and her POMS service have inspired many of you. For those of you that haven't already, check out hashtag POMS on Twitter, where more service development nuggets are bound to be shared. On to this month's session. A few weeks back, I interviewed sports podiatrist Ian Griffiths about a variety of foot and lower limb related issues. During our chat, Ian mentioned the orthoses lab that he uses, and when we contacted them to let them know about the podcast, they kindly offered to sponsor the episode to help us cover some hosting and streaming costs, so many thanks to them, and me and Ian will let you know a little bit more about their ethos and things after the show. But before that, let's get to session 18 with Ian Griffiths. Welcome to the podcast, Ian. Would you like to introduce yourself?
Hi, I'm Ian Griffiths, prefer to be called Griff. I'm a podiatrist. I work in consulting 5 different clinics, 4 in London, 1 in Dublin. And much like yourself, I'm one of those nerdy individuals that has a real passion for my chosen career, my chosen profession. And I'll take any opportunity to try and promote it in the best light I can, which is why it's awesome to be invited onto a podcast of this caliber. And I think I'm right in saying, correct me if I'm wrong, that I'm the first ever non-physio.
Oh, I'm afraid you're not.
Oh.
No, you're the first podiatrist. We're like our first, but no, there's been a couple. We've had a psychologist, we had a pharmacist, but nice try. Now, tell me a little bit about your clinical journey so far, but rather than reeling off an impressive CV, it's still a CV, I'd rather hear about how your thought processes might have changed over the course of time.
Yeah, it's an interesting one because my biggest fear has always been and continues to be sort of professional stagnation, i.e. my thought process is not changing or not developing or evolving. And you sometimes worry about getting caught in a rut or just doing what you always do and not being challenged. And I think it's a bit like putting on weight. You don't know you're putting on weight on a daily basis, but if you look back over to a photo a few years ago, you realise how much you've changed. And I didn't really think my knowledge had changed that much because it had been happening so gradually. And I was clearing out my study last year, and I found some notes from my degree, my bachelor's degree. They must have been 2001, 2002. And I read them, and there wasn't a single thing I'd written that I currently still subscribe to or currently still apply on a daily basis. Wow. So it really kind of opened my eyes as to how much my thought processes have changed and they have evolved. And I think probably a couple of things have facilitated it. Obviously CPD, conferences, talking to people, professionals, colleagues, etc. But the biggest thing for me was moving into private practice, which I did around 06, 07. And the reason that was such a big deal for me is when I moved into the NHS, my first job, it can be I don't know what it's like in physiotherapy, but in podiatry it can be very you can be a very isolated role
at times.
Yeah, so quite often you're sitting in a room just on your own, sitting in a clinic or a health centre on your own. If you are in a joint clinic with other professionals, then normally other podiatrists, and there just wasn't really any learning outside of podiatry. And given that we'd all been taught the same thing, i.e. those lecture notes, it was only when I moved into private health, and not so much, it's not an NHS versus private thing, this is a isolated versus multidisciplinary thing, really.
Yeah, okay.
Moving into clinics with physiotherapists, doctors, etc. That I feel that's the time when my own thought processes evolved rapidly, changed rapidly.
So would it be fair for me to say that the lack of exposure to other disciplines meant that you inadvertently became a bit complacent in your own thinking or development? Is that fair enough?
I think so, yeah. And I think I've always tried to surround myself with good podiatry mentors, and I have a couple that I'll mention later that I really respect and that have hugely brought on my thinking. And I try to read work by certain individuals as well. But what I'm talking about really is believe it or not, things like load management, proximal control, which is so fundamental and such daily occurrences in my own thought processes now that we were just not taught as part of our bachelor's podiatry degree. And moving into a multidisciplinary team really pushed that side of things on for me and completely evolved me as a clinician. So my change in sort of podiatric theories and paradigms probably didn't come from the multidisciplinary team, but my change in how I treat patients in front of me hugely influenced.
Right, okay. Now, that's great. And you've just touched on a few of the things that have become more contemporary things in your practice, load management, except proximal control, just what you've used. Let's talk a little bit just briefly about what was then. So what did your study then make you founded in?
So I think talking purely musculoskeletally, because that's the field, as you know, I've kind of moved into. You do study the entire limb when it comes to podiatry, hip down. But without doubt, the majority of the focus, the emphasis is obviously the more distal. So your foot anatomy and examination is thought to be your strongest point. And then if you move up to the knee, you should have it, but it gets a bit weaker. You move up to the hip, and often it's very, very poor. But I don't know whether it's still the same. I'm obviously referring back a few years here, but certainly the education that was given at bachelor's level was a very, very historical model of foot function and assessment and treatment. And as I say, one that I'm almost unbelievably saying it, but I don't really subscribe to now, some sort of 12, 13 years later.
And to frame it differently, I've been fortunate enough to attend lectures and seminars of yours on topics such as what we're discussing today. And a strong conclusion I've come to is that you're not a fan of the word overpronation. So for the sake of our listeners, rather than for me, can we talk a little bit about that? Why is that?
Well, I'm glad you've picked up on that.
It wasn't hard.
It is something it's a drum that I've been banging for a while. And believe me when I say, this isn't I'm not the only person that has a problem with this. This isn't my thoughts and theories. It's a very, very commonly held opinion based on the evidence base or lack of evidence base.
Yeah. Well, sorry to interrupt there, but commonly.
Well, sorry, yeah.
And we'll come to that a bit more, but, how commonly, I suppose, is contentious.
Common within the group of people I surround
yourself with. Yeah, cool. And we'll come to that and we'll flesh that out a little bit later. Sorry, do go on.
No. I mean, you're right to bring that up because I've always tried to surround myself with people more intelligent than myself, which I find remarkably easy to do.
Apart from today.
So whether I try not to be the cleverest person in clinic because the cleverest person in clinic is never going to learn anything. And again, luckily that's rare for me. And my podiatry mentors just blow my mind with their level of thinking. So it's really that group of individuals I'm talking about, perhaps rather than the global kind of population.
No, fair enough.
Yeah, no, you're right to call me on that one. We'll perhaps talk about that.
Definitely will. Yeah.
So I've written about this before, and I've spoken about it before, and at the risk of sort of boring you and saying it again, I've been slightly misquoted on it in the past, and maybe this is a pretty good opportunity to set the record straight. But when I first wrote a piece on it about the problems I had with this term overpronation and the approach that it dictates, I had a few people sort of off the back of that say, "Yep, I agree. Overpronation doesn't exist, or it's poor. Therefore, orthoses are inappropriate, or therefore barefoot running is the way forward." And actually, I feel like that really wasn't the message I was trying to give. It's just as applicable. My thoughts and theories on this are just as applicable to other terms. So they're just as applicable to the ugly cousins of overpronation, such as underpronation and oversupination. They're all undefinable, ambiguous terms. And my problems with overpronation are just as easily applied to those terms also. And the reason I pick overpronation to bully slightly is that it's the most commonly used. And if you say it to a group of people, they can hopefully resonate with what you're trying to say. So it's really an issue with inappropriate and unscientific terminology. And that sits on top of essentially a model of assessment and treatment, which doesn't sit very comfortably with me. It's very poorly evidence-based. I just feel that it's it's not the most appropriate way to treat our patients.
And from what I gather, the word, is not in keeping with the entire ethos in which you assess and treat the foot. So what can we just try and break that down maybe into two or three things? Is what is it about overpronation as a concept as well as a word that is flawed scientifically then?
Yeah. Well, maybe it would help if we lay out what the current model is. What the model we're talking about is essentially that we are all taught a textbook definition of ideal or normal being a word that we'll use cautiously, but we're all taught the parameters of normality, or what is perfect or optimal. And then we take that into our clinics, we assess our patients, we observe our patients, we look at their foot posture, statically, dynamically, hopefully both, and we then categorize them or give them a label, such as overpronation. And then off the back of that, we initiate a treatment plan to get them back to that predetermined textbook definition. So just to clarify, that's the model that I'm sure you were taught maybe, and I know I was taught.
No, absolutely.
And I'm sure many people, I don't know whether it's still being taught.
It certainly is from what I can tell, but also that's more with my physio hat on, I guess. But it happens across the body. Normalising is something that has come up in a number of podcasts. So, no, please do go on.
So that's the model. And, when you ask me what my problems are with this, they are many. I mean, at every single...
I want you to, let's systematically go through them.
At every single stage of that process, I think if we're looking with an eye on sort of an evidence base, we're found wanting. So we start off with our textbook definitions of normal, which of course have no scientific backing whatsoever. The concept of subtalar joint neutral being king has been around for many decades, and it's just never ever been shown. Moreover, the subtalar joint gets an inordinate amount of attention when it comes to the foot, almost like the foot's been modelled as some rigid body that rotates around just this one joint. And we know from good data, from the work of sort of Chris Nestor and colleagues, that it's just far, far more complex than that. It really is. The contributions to foot movement, particularly pronation and supination, from other joints such as the tibio-talar joint and talonavicular calcaneocuboid joints, mid-tarsal joints, is vast, and in some individuals more important than the actual subtalar joint. So what the bone pin studies that these guys have done have shown us is that the foot's about as complex as it gets. And when we talk about that old model of normal, define normal, look for abnormal, realign, or however you may term it, that's a very, very simple algorithm. So why when we've got the foot, which is anything but simple, would we be so accepting of an incredibly simple pathway to treat it? It just doesn't seem to sit right with us.
No, absolutely. And therefore, when we talk about assessment of that, I suppose the next level, if you don't mind me putting it onto that, is then your issue with the validity of the common assessments of something you already disagree with. So it's got layers, hasn't it?
It has. We disagree with the concept of normal, but let's assume we agreed with that, and we then move on to measuring this or defining this. 2 points really. How we clinically quantify pronation, supination is different person to person, and some people use one method and another method. We won't go into all the different methods here, but the reality is that the reliability of these methods, so essentially how comparable my measurement would be to your measurement on the same patient, is poor. It's not been shown to be great, both inter-rater and intra-rater. So whether that's me measuring the same person on different days, or you and I measuring the same person and being different measurers, the reliability has been shown to be poor. And the second sort of arm to that is, even if we could measure this reliably, and then we were going to put people into categories of, let's say, normal or overpronators, where are the boundaries? Where is the line drawn where someone becomes an overpronator? Is it at 4 degrees or 5 degrees? And the answer is, again, we do not know.
There's a massive amount of kinetic, kinematic, and anatomical variability between people that is therefore difficult to quantify. And apparently, from your work that I've sat in on, there's anatomical variability from right to left, never mind from person to person in some people.
Yeah, absolutely. When we look at the orientation of joint axes, even when we look at the anatomy, the architecture of this, let's say the subtalar joint, so where the talar sits on top of the calcaneus, some people have 2 facet joints and some people have 3. I mean, we are that different person to person. So why we should all be accepting of behaving the same, again, it's almost more surprising that we've accepted this for so long. So we don't agree with normal. We essentially, and we don't just not agree with it. There's no evidence for normal. We find measuring these things very, very difficult from a reliability perspective. We don't really have these lines drawn in the sand where we want to categorize people. So, and even if we did, it doesn't seem we can measure people reliably enough to put them in the right category anyway. So the categories don't exist.
Yeah.
You may put someone in a different category to me. So the whole thing starts really crumbling apart when we look at it through an evidence-based kind of lens. And then the final point, which probably what we to get onto, is how this dictates treatment. Well, historically, it's been if you're not vertical or neutral, you're not right, and we just know that not to be true, both clinically, both academically, and as I always say, if you try and realign every single person you see to vertical, you'll hurt as many people as you help.
No, that makes sense. Now, it's almost a given for us to therefore go into treatment under old parameters. If not to normalise foot and ankle function, then where does the evidence base lead us in terms of assessment and treatment? So we've stripped it back, and you've said the whole foundations of what we've come to understand about foot function and how that translates into things like biomechanics, and then we'll talk about pain, of course. But if not that, then what? What do we bring forward?
Yeah, it's a great point, and the fact that we are still persisting with the old model probably suggests that there's nothing that everyone's completely accepted to replace it with, or at least they're not aware of it yet. And when we use the word normalise, and we've touched on the word normal 2 or 3 times already, again, I just think we have to be so cautious applying that word to the human body in general, but particularly the foot, because we just don't really know what normal is. And there's actually some work being done by a group of guys down in Australia at the moment called the 1000 Norms Project, which is worth looking into if anyone's into this kind of thing. And they published 2 papers just a few weeks back, one in physiotherapy and one in the BJSM, which I can give you links to, obviously. And they made a really interesting point. It was Josh Burns and his team there made a really interesting point in one of the opening paragraphs, which I really liked, which was that normal, we need to actually define what we mean by normal, because if we say normal, the first thought may well be, oh, that means pain-free or asymptomatic in that context. But actually, if you're talking to someone who's collecting data, normative data, you're looking at normal distribution. Normal often means the mean, i.e. the average.
Yeah. And
the average and what would be considered unpathological or asymptomatic can be very, very different things. And I use foot posture index as an example. The 2 big studies that I'm aware of that have looked at the normative data, so the foot posture index in pain-free individuals, healthy subjects, both kind of agreed that the normal, so I think the mean foot posture was +3. Now, does that mean that everyone who's +3 is normal, i.e. will never develop problems? Of course not. Does it mean that people who have a foot posture greater or less than that will definitely develop problems? Of course not. So this is the problem we have with the word normal. You're always going to have outliers or deviations from the mean that are absolutely fine, and you're always going to have people sitting smack bang on the mean that aren't doing so well. So normal is a really, really interesting word, and one that I try not to use for that result, for that reason. Sorry.
So then we come to, like I said, where do we go then? I say we. What do you therefore assess? Well, how do you find yourself approaching it so differently?
So what I apply is what we refer to in podiatry circles, at least, as the tissue stress approach or the tissue stress model. Now, it's just a theory, like all theories and paradigms, and it's not perfect. But for me, it has the best evidence base. Its evidence base essentially being anatomy and physics, mechanics, which have pretty much stood the test of time, I think it's fair to say. And also, in my own mind, it's the most biologically plausible, theoretically coherent sort of approach. So it's the approach that I apply. And again, I'm not alone in applying this approach. I'm not a trailblazer in this regard. I'm very much an amalgamation of the more intelligent people I hang around with, the things the shoulders of the giants I stand on, so to speak. Okay. But this tissue stress approach, saying it to a physiotherapist, this may seem very strange to you, but you've got to remember where we come from in podiatry with our education about being taught normality and abnormality. And the tissue stress approach is an approach where someone presents to you symptomatically, usually, obviously.
Yeah.
And it's a kind of 3-step process, to put it in its simplest terms. Step 1, work out what hurts. Step 2, decide why it hurts. And step 3, devise a plan to stop it hurting. And that sounds super simplistic, but let me just sort of clarify. Let me put an example of the old model into that framework and show you why it doesn't work. Let's say, and I know you've heard me sort of mention this example before, but patient walks through my door, high index of suspicion for a tendinopathic tibialis posterior. I throw them on the treadmill. I'm applying the old model. I say to them, okay, I can see your problem here. You're an overpronator. And he says, oh no, that's what I was afraid of. You say, no worries, we're going to sort you right out. Here's a shoe or an orthosis or whatever it may be to realign you back to normal. You'll be right as rain. Come back and see me in a couple of weeks. Everything's good. Patient number 2 comes in straight after. High index of suspicion for a peroneal tendinopathy. We get them on the treadmill. Just by coincidence, they look very, very similar to the last person, positionally, kinematically. You sort of say, oh, here's your problem. You're an overpronator. And they say, oh, I've heard about this thing. And, you give them, ironically, pretty much the same treatment because your goal has been to realign people. And you think this job's easy, But if you really look at that with a scientific lens, how can an intervention to offload a structure on the medial aspect of the ankle be exactly the same as an intervention to offload a structure on the lateral aspect of the ankle? And the answer is it can't. It just defies mechanics and physics. So the old model, that 3-step process of what hurts, why does it hurt, how do we stop it hurting? I guarantee everyone will be like, well, that's obvious. Everyone does those 3 things. But actually, if you apply the subtalar joint neutral, normal kind of model, you're really not actually applying that. And actually, what hurts and why it hurts, those first 2 steps kind of become irrelevant if step 3 is always the same.
Yeah.
So enter tissue stress approach, which is use your understanding of anatomy, your history taking skills, your palpation skills to identify what you believe is the symptomatic tissue, the pathological tissue, whatever you want to define it as. Then, moving on to step 2, use your understanding of, again, functional anatomy, biomechanics, physics, to try and identify, any patterns of movement that you feel rightly or wrongly may contribute to the overload of that tissue. And then step 3, your management plan is to devise a way of changing the pathological levels of load on the injured tissue. And it probably sounds super simple to a physio. I'm sure you may have done this for years, but I mean, in podiatry, this isn't done by everyone. And we kind of pull on the works of Hunter back in the late 90s, who, for me at least, when I read his paper, it was in manual therapy, it was the one that best described to me how tissue overload and dysfunction occurs, which was new to me. And then the work by Michael Muller, early 2000s, essentially how tissue responds to physical stress, and his thoughts on if you overload a tissue, then tissue injury or even death may occur, and if you underload a tissue death may occur, hence giving us this concept of this zone of optimal load.
It's one of those seminal papers that really gave that idea of tissue homeostasis through.
And the crazy thing, that was published in 2002, and I sat my finals in 2000, my biomechanics finals for my bachelor's degree in 2003. So that paper existed when I was taught. Yeah, I wasn't taught it, but it's completely and utterly at the front of my mind with every single patient I see. So those 2 papers, amongst others, and again, your own clinical reasoning and all of those kind of things that we always know are important, essentially help you treat the patient in front of you as an individual, embracing their variation, with the main goal of trying to offload the injured tissue.
With regards to that as an example, when you were treating the, say, tib post tendinopathy and peroneal tendinopathy, the awkward thing is when the intervention for both of those people, and we'll come to why that might be successful to some extent in both of those, and then it comes into that awkward where that correlates with pain. Just to ask you a little bit more about the typical thing that we would understand, and it might be unfair of me to say, but to prescribe devices is what we would come to understand as being a fairly typical thing a podiatrist would do. Now, in that circumstance, what would we say, to summarise for our listeners, an orthotic device does? And I know that will vary, but in those sorts of circumstances, when you determine that that's going to try and offload, what level of mechanism of effect, what do we understand of that?
So let's first of all talk about how we used to think they worked, and perhaps we don't. And that ties in very much with the debunking of the normal theory. I mean, the classic picture being the before and after of a very everted calcaneum, and then before, after, or bad, good, however you want to frame
Corrected,
it.
Yeah.
And that very, very vertical calcaneum on sitting on top of the device. The picture that sells 1,000 orthoses. But the reality is that's, again, a poorly evidence-based kind of thought process now. Now, when we're talking about do orthoses introduce kinematic change, do they change angular positions? They can do. They don't in everyone, but they certainly can do. But if people define changing kinematics as realigning or placing the heel in vertical, it's very, very rare. I mean, the systematic review done on mechanisms of foot orthoses in the BJSM, when it looked at the kinematic mechanisms, it suggested that on average devices change the rear foot by 2-3 degrees. Now, of course, they probably have much more profound kinematic changes across the midfoot, and that's often not measured because things get very, very complicated. But the reality is that the old kinematic model, which I was certainly taught, and I believe I'm right in saying most people are taught, which is orthoses work by realigning the skeleton, is not the most appropriate way to currently think. And I often say to people, both professionals and patients, we've got to stop thinking of these things as arch supports. We've got to stop thinking about them as skeleton realigners. It just isn't really what they do. They are an external device that applies load to the body, and in applying an external load, you will be changing and manipulating internal loads. So just think of them as just one arrow in the quiver of load management. And I've spoken to people, and as you know, orthoses can split opinion. Some people are very pro-orthoses and give them out way too much, and that definitely happens. They are overprescribed by some. Some people are very anti, and won't even entertain them as being an option. And the interesting thing for me is that when I speak to people in the musculoskeletal field, when we're looking at lower limb overuse injuries, no one really disagrees that the lion's share, 90% more maybe, is a load management issue, more often than not. And our interventions are therefore based around introducing more appropriate load management, whether that be asking our runners to back off of their running initially, which is, again, a load management strategy, whether it be giving them rehab to increase the actual tissue's load capacity, so how it can tolerate load, whether that be gait re-education, stride length cadence. All of those things are essentially manipulating load. And the same people that I've spoken to in the past that are very pro that will then be completely and utterly anti-orthoses. And all they are is another tool to modify load. They're not for everyone, but they're not for no one. It's that false dichotomy of assuming that they're either for everyone or for no one. You've got to pick your patients, you've got to pick your pathologies, but we certainly don't feel that the realignment of the skeleton is the current most scientifically answerable mechanism for how they work. So a very, very long-winded way of getting back to your answer.
It's good, and I think it's sensible to say what it doesn't do is a classic, because I suppose the most standard use, I would say, in my experience, is that a visible that foot is pronating more than I would like it to. Therefore, this device is going to block or stop or decelerate that motion. Now, that, from what I'm gathering, is a fallacy. That would be what it was doing on that mechanical level.
I agree. And the crazy thing, if you're still thinking on that level and you introduce that device, you may still get a positive outcome, but it may not be the reason you think you get a positive outcome.
Exactly. Yeah.
So if we take aside sort of psychological effects, because they're complex and outside the confines of what we can talk about, and also neuromotor effects, which we can't ignore. So you put something underneath the sole of the foot and you get this sort of central nervous system driven sort of change. So some kinematic changes we see at foot level aren't true mechanical changes. It's not the foot being pushed. It's essentially the central nervous system's response to that device.
Yeah.
And we've seen people pronate more on inverted devices. And you try and get your head around that mechanically, it's never ever going to work. And that's probably where neuromotor effects come in. So neuromotor and psychological, we don't talk about much. We don't measure in clinic because we often can't, but we can't ignore them. They're there, and they exist. But where the largest body of evidence seems to point toward is the kinetic effects. So the forces, and I know the kinetics, we often talk about them separately and artificially delineate them, but they're obviously very, very intertwined. And this comes back to Newtonian physics, and, motion and force, etc. But the current data suggests that they have a far more profound kinetic effect. And also you will have a kinetic effect of it in every single person you give a device to, whereas you won't necessarily have a kinematic effect. So they're the things to get for people to get their head around. You can put a device under someone's foot and it might change the alignment. It will always change the force, and it doesn't need to change the alignment to change the force. And the analogy I'll steal an analogy from my good friend and mentor, Dr. Simon Spooner, who just describes this beautifully. And he talks about children on a seesaw. This is the easiest way to get your head around that kinetic sort of separation. Is you imagine you're in a park and you see some kids on a seesaw. And a kid goes over and jumps on one side of the seesaw, and what happens is that seesaw tips, and that kid's now essentially sitting, not on the floor, but the seesaw is touching the floor. Mm-hmm. The other end is up in the air. If you measured the, let's say, compressive force between the underneath of that seesaw and the floor, it would come out at, let's say, X newtons, whatever it may be.
Yeah.
If another kid comes along, jumps on the same end of the seesaw, there has been no kinematic change. That seesaw has not changed position whatsoever. Yet if you measure that compressive force between the seesaw and the floor, it will have increased, doubled perhaps.
Absolutely.
Now, if you measure that kinetic effect and you get one kid to jump on the top high end of the seesaw, hope you're still with me, so you've got two kids on one end and one kid on the other end, the seesaw probably still won't have any kinematic or angular change introduced. If you now measure it, it's reduced again. And if you imagine the fulcrum of the seesaw as, let's say, the subtalar joint axis, and if you imagine the seesaw as let's say the talus and the floor as the calcaneus, what we're possibly talking about is something like sinus tarsi syndrome. Mm-hmm. So introducing a device which changes compressive force in the sinus tarsi, but hasn't introduced any visible angular change. So these are the concepts to get our head around. They're physics concepts, but we often have been very, very guilty of looking at a device in a shoe. It doesn't visually change anything, and we flippantly sort of say it's not working. And it's obviously far, far more complex than that.
It's baby out of the bathwater.
Yeah, absolutely.
Makes a lot of sense to me. Makes a lot of sense with regards to what we've come to conclude from a number of other guests we've had on the show. So if, as we've talked about before, it's not commonplace across your profession, and I would certainly agree not across my profession, at least at the foot level, why isn't it?
I think, and it's just my opinion, but I think it's probably because it's incredibly complex. The old model, there is no denying it was simple. Doesn't make it right, as we know, but simple. People like simple. Clinicians like simple. Patients like simple. Salesmen like simple, dare I say. So the reality is something simple will always stick more than something that requires an incredible amount of thought. And it's not black and white. Whereas the old model was very black and white. And, essentially the cookbook approach, if you like, to biomechanics. I'm a terrible cook. I'm an awful cook. But you put a recipe in front of me, I can make something that resembles something okay. It doesn't make me a good chef, though. And, the old model can take people who perhaps are new graduates or perhaps they're not completely confident in this area, but they can apply that sort of recipe cookbook approach to the foot and ankle, and essentially, dare I say, in a cynical manner, make money privately from doing so,
and yield some results. Well, for some of the reasons we'll come to talk about.
This is the crazy thing, right? You don't necessarily need to know what you're doing to get a positive result, but the time you do need to know what you're doing is if you apply that cookbook approach and that patient doesn't get better. Because if all you apply is that cookbook approach and they don't get better, where do you go? Where do you go from there?
Absolutely. And with regards to that complexity, having spent some time with you clinically and spoken to you off the microphone before, I know full well that what you're not proposing a really complex dichotomy of treatment that you then sell to a patient and start getting your millimeter rulers out. You're saying that the reasoning can be complex and the situation is complex, but you can then still simplify the actual outcome. Is that fair for me to say?
I think so. I mean, the reality is, and I think on your podcast with Greg, which I thought was brilliant, I really did, he made a really great comment, which was, we do try and overcomplicate things sometimes, and we should try and keep them simple. We really should, particularly when we're communicating with our patients. And I completely agree with that 100%. But my problem is at foot level, the model has been simplified to a point where it's ridiculous. To a point where it's false.
Yeah.
So I think, the way
it's not been complicated enough. A lot of the stuff that Greg was talking about is that people have overcomplicated for years.
Yeah.
In your field, it's been undercomplicated.
I think so. And, probably should have said this earlier when you asked me my problems with overpronation. But, along with all of those kind of clinical problems, the real deep down problem we have with it is that in accepting it and perpetuating it for so many years, we have dramatically held back the development of our understanding of the human foot. And that can't be a cool thing.
No, absolutely. And also the branding of people with that term is something I know you don't agree
so,
with.
as you say, I'm very, very keen on trying to simplify these concepts as much as possible when we're talking to our patients. But that doesn't mean we should simplify them when we're talking to each other.
Absolutely, and that's a great point, and that's why clinical discussions that we need to recognise the difference between the interactions we have between each other, and why this isn't a public-facing podcast, I guess, is because we need to talk about the geeky stuff sometimes and flesh that out. Now, we're talking therefore about it brings us on to communication, something that I know you value highly with regards to history taking, etc. But how do you approach the topic of pronation or over-pronation with a patient who firmly believes in it as a causative thing with regards to their symptoms, or even their problems further proximally, their earache even?
It's interesting in that we can't really get upset with the patient or blame the patient when they come in and make these comments, when between us, we know that, not us, you and I, but between us as professions, we're guilty of doing the same. And if we're doing it as professionals, and if the running stores are perpetuating it, and the running magazines and the running shoes, etc., why are we surprised when a runner comes in and I say to him, "What's the problem?" and he says, "I'm a pronator," to which I normally, depending on his character, will sarcastically reply, "Oh, thank goodness for that," or "Me too," or something along those lines. But this is the problem. Overpronation, as a ridiculous term, has got so much sort of attention now. Pronation is a term that is revered, and you sort of think we've got this all wrong. We talk about how terrible the model is, and another thing that people will often say to me, and I'll often say to a patient, if they're the right kind of patient, judge their character. If they say, "I think I overpronate," I'll sometimes just say, "Yeah, that's not a thing," and see how they respond. I try and have a bit of fun with it.
I do like doing that. No, that's not a thing. Now, you've got to pick your patients, you're right, but in a variety of different body parts or reasons, that sometimes is a good way of saying, no, and let's talk about why not.
And, patients have said to me, and, even when I've given my talk on overpronation, I've had other professionals say to me, "Okay, I hear what you say. Maybe they even agree. They don't all agree, but if the ones that do will sometimes say, if not overpronation, then what should we use instead?" And they've missed the whole point. The word is not the problem; it's the model that it's based upon. And I actually, you can call it Danny Dyer's chocolate homunculus if you want. The point being, doesn't matter what you call it, the approach, the model that underpins it, the thought process needs to change, and that word just is the cherry on the top. So I'll often, again, depending on the patient, give them this level of detail. Sometimes I'll skim over it. As you sat in clinic with me, I don't use the word pronation in clinic. I don't give it any more attention than it deserves. I can assess and treat and explain management plans to patients without using the word pronation. I'll often talk in terms of movement or rotation, but I very rarely use that word.
Did you have to forcibly eject it from your vocabulary?
Absolutely. And it will still slip in now and then. And, if I'm ever talking about pronation in a consultation, it's because the patient has asked me about it. what about this pronation? What about this overpronation? Or the other one I hear a lot is a patient coming in saying, I pronate more than I supinate. And this is a really, really interesting comment, because this, without the patient knowing, because the patient hasn't studied this, and the patient doesn't know about subtalar joint neutral theory or normality. But actually, if you break down this comment, it's completely and utterly entrenched within that model. And to give an example, and this is what I'll often say to patients, when they say, I pronate more than I supinate, my first answer is, you don't. You pronate exactly as much as you supinate. And I just do it to get a bit of a reaction and see what their face is like. And again, I'll often use an analogy. I'll use it here if I may, and that is of a lift in a hotel. So let's assume you go in at ground level, and this lift goes up 5 floors, and it goes down 2 floors. So there's 8 floors, including the ground as well. If you go on at ground floor and you use that ground floor as your reference point, the lift goes up 5 floors from ground, it goes down 2 floors from ground, therefore people would conclude it goes up more than it goes down. But it doesn't, right? Because the reality is, if you take away that reference point, ground floor, which is the analogy here for subtalar joint neutral, it's a lift that serves 8 floors, and it goes up just as much as it goes down, because it goes up from the bottom and down from the top. So pronation, supination are movements. They are ranges. People don't pronate more than they supinate unless they are referring to this artificial reference point, which we already know is nonsense. So those kind of comments that even just a person coming in who's never studied subtalar joint neutral theory or the foot in any way, they're making comments that they've read or heard, which are completely and utterly sitting on top of this theory that we're trying to change. So yeah, it absolutely fascinates me. And I genuinely don't take it too seriously. I try not to take myself too seriously.
No.
And I'll often hear, these things that patients say, I'll listen to with a smile on my face, and depending on their character and personality, and depending on the mood I'm in, they'll either get a long answer or a short answer. But yeah, it's something I do. I spend an awful lot of my day doing.
And that's something that's interesting, because when I asked that question, I know full well you could have given 10 different answers of different ways you approach it. Now, instead, the fundamental thing was, we've got to be brave enough. I say we, just generally, if you're wanting to just explain this or try and reassure someone that that's not necessarily the case, the first thing you said was, yeah, that's not a thing. And in a roundabout way, not necessarily as bluntly as that with certain people, but we've got to get there. We've got to be comfortable debunking that and challenging that belief. And instead of giving those 10 different ways you could do that, just start there and use sensible analogies such as the one you've just used to try and make it simple for patients, which ties into an awful lot of the other podcast stuff we've done before. So that's brilliant. Does it differ how you explain that with Joe Public and more athletic population?
It's a good question. I think it probably does. Well, the way I explain it, we were talking about this morning in clinic, I'll try and modify my own behaviour depending on the patient in front of me, if I can. So whether they want to be a bit more serious, whether they want to be a bit more relaxed and jokey, whether they want all the data. In London here, we see people who work on the trading floor. They deal with facts, they deal with numbers, data. They're data-driven, they're type A personalities. They sometimes want the science. And if someone wants the science, I'll give them the science. But at the same time, someone may not want the science. I see professional footballers who don't care for the science. They want to know how they can get better quickly so they can play again. I see a lot of professional golfers. They love the mechanics. Probably a narrative on how much time they spend analysing their own swing, for example. So I try and modify my descriptions to the person. And rather than bracket it into Joe Public and elite, because some elites like footballers don't seem to like too much info, whereas golfers seem to. Again, in Joe Public, engineers love it, as you can imagine.
Yeah.
Whereas some people, the first thing they do when they walk in the room is they look at their watch and they say to me, I need to be out, I've got a meeting at 12. They've not got time for seesaw analogies. They just need to trust that I am going to know what I'm doing, or hopefully try and help them.
Brilliant. So it's not necessarily an athlete versus Joe Public. It's just very individualised.
I think
that's
so.
what you gather across the subjective history.
In my experience, yeah.
Fair enough. We've chatted a bit about what orthotics do and what they do and what they don't do, but I wanted to just wind back to why then, in those cases, little case studies that you gave, why the same pair of orthotics would get a positive result potentially. You're looking to decrease pain. Two patients with different pathologies, but both with the same treatment get the same result. How do you see that and why that might occur?
So it's difficult. That obviously you can never rule out psychology and, as we said, neuromotor effects. But if we're purely thinking from a mechanical perspective, which is, as you know, very much my bias, so I find it difficult not to think that way. The gut feeling that we have is you've introduced change. So you introduce change, and you change the way tissues load. So as we've already talked about, external devices will apply forces to the foot, and external forces will change internal forces. It's just kind of simple physics. And the question becomes then whether our short-term intervention, which brings about short-term relief, whether that be mechanical or by other mechanisms, is something that is going to be needed or useful or maybe detrimental in the medium to long term. And that's the big thing, particularly with peroneal tendinopathy. If you purely look from a mechanical perspective, the way to offload the peroneal tendons, mechanically speaking, is to increase pronation moments. I remember speaking to Craig Payne about this years and years ago, and he told me the first time he actively pronated a foot, he felt like he needed counselling. Genuinely, he called up a friend and said, "I'm just not sure I've done the right thing." That's how ingrained, even in very, very intelligent men, that's how ingrained this historical paradigm is. So I think, we need to look at these, as we said before, just to repeat, they're load modifiers, they modify load, and like you say, you introduce a change, and you may well get a change in tissue loading, which short-term will bring about pain, but long-term may not be appropriate.
Fantastic. No, that's great. So in that circumstance, when could we say, this is the toughest, biggest question, I suppose, we could do a whole podcast on this question, but when are they indicated then, in terms of, is how much of a priority is it in your practice and what you would deem to be appropriate?
So, let's address the elephant in the room, which is that I'm a podiatrist. So the impression of me will be that I dish out orthoses to every patient I see. And I wish I could sit here and defend my profession in that position. But the reality is the reason we have that, there's a reason we have that reputation. And that reason is that does go on. Not myself personally, and certainly not everyone, but there's enough people doing it that there's no smoke without fire, so to speak. I'm pretty confident that if you asked any of the clinicians, physiotherapists, etc., in across the 5 clinics that I work in, whether I give orthoses to every single patient I see, they would laugh. It's one of the last things I do. And I know that sounds ridiculous as a podiatrist, but it genuinely isn't always at the front of my mind. Certain pathologies I'm much more confident with, and certain pathologies in the context of certain patients and certain movement patterns I see, I'll probably lean that way much, much sooner. But, things like patellofemoral pain, we see a lot of patellofemoral pain here. We use a very sort of multimodal joint approach. The big debate about whether it's distally driven or proximally driven, is it a bottom-up problem, a top-down problem, is it a bit of both? I probably wouldn't go orthoses first line, even as a podiatrist. If someone walked in off the street and saw me and presented with what I felt was patellofemoral pain in origin, I would guide them towards the physio before I did anything. And I'm not alone in that, of course. When you start getting more proximal, and when we touched on this earlier about people saying that their orthoses will help cure back pain and shoulder pain and TMJ pain, it will take some convincing for me to believe those sorts of comments. I believe they're more underpinned by marketing than they and money making guruism than they are science.
So beyond the knee, the body can adapt to those forces and those changes enough to make them not that important.
Yeah, well, I think for me, and be careful what I say, because it's just an opinion really, but I think for me, when we contemplate the body as this sort of multi-segment kind of chain, we introduce something at the bottom of the chain, and we look into the data of how variable the coupling between segments is in individuals. The more segments we get away from the device, if that makes sense, the higher up we get, I just feel the less convinced we can be, scientifically speaking, that we're doing what we think we're doing, if that makes sense.
No, it does, yeah, absolutely. And I suppose that's where I've tried to say at the knee. I'm not saying we have to stop at the knee, but it becomes less and less feasible that we would be making the changes that we would higher up.
I think so, personally. I see a lot of kind of knee pathology and down. I'm not saying I never see higher up pathology, sort of at hip and lower back, and suspected leg length discrepancies notwithstanding. Orthoses are very, very much at the back of my mind if I'm being asked for an opinion on things as high up as the pelvis, personally. And again, if you'd have asked me this 12 years ago, maybe you'd have got a different answer.
And now, I know you're a diplomatic and pragmatic person, therefore I don't want to drag you into something too difficult, but there are certain systems out there or certain paradigms in which people are determining that the foot is the root of all heartache almost, and that a dysfunction, whatever that might be described as, is driving poor biomechanics throughout the system. Now, I think we can gather already from our chat that that's not going to sit well with you, but where is it most flawed in that circumstance?
I mean, my gut feeling is if anyone claims to have all the answers, then immediate skepticism is required, because none of us have all the answers. We don't fully understand the human foot. I mean, you talk to people who are just geniuses in this regard. They've published numerous papers. One of my absolute heroes, Chris Nestor at Salford University. I'm sure you ask all these people, do we know how the human foot really works? Have we got it all sorted? And these guys will say, absolutely not. This is a work in progress. Because they're scientists. And I think when you then hear people, whoever they may be, mention that they have all the answers and it's all foot-driven, for example, how on earth can they be so bold to make that comment? It just doesn't sit well with the available science, and certainly the people's opinions that you respect aren't saying the same thing. And I think like I say, coming back to the point of we keep coming back to is we need to embrace variation. And the foot is not going to be a problem for every single person. By the same token, don't swing the pendulum too far the other way and assume that it's never going to be a problem for anyone, because it will be. Yeah. And I think that's the problem, that what Ross Tucker calls the false dichotomy, or the wrecking ball of opinion, where you basically, if you swing it too far, one way, you build your opinions on the rubble that's left. I mean, ultimately, the answers aren't going to be, or rarely going to be, at polarized extremes. And the foot's a classic case of that for me.
Because there's incredibly popular fields of, I can't call it study, of opinion that suggests that a left-sided ankle sprain at childhood would drive poor biomechanics to then the patient presents with no lower limb pain at all and a contralateral shoulder problem, that therapist has deemed the issues at the foot and ankle to have driven that. Now, there comes a point where we've got to sort of call BS on that, don't we, to some extent? And we've got to be brave enough to stand up for ourselves scientifically, right?
I think so. I mean, we, in the same sentence, in the same context that we don't know it all, we have to also keep open minds, but not so open that our brains fall out. And the reality is we're scientists, and we are driven by science. And we don't want to get too upset by these things, and we certainly don't get wound up by them, or they don't keep us awake at night. But we have a duty as professionals who are demanded to practice evidence-based medicine, and as scientists, and we have a duty to apply scientific rigor to anything we read. It's not attacking someone; it's challenging someone. It's healthy. It's critical appraisal. And sometimes you see things or you read things and you just think, on what planet would that be considered an appropriate thing to say without some evidence or without some data? And unfortunately, quite often this position will be set up that because we don't have all the answers, Science doesn't have all the answers, so therefore I'm providing this. Well, just because A is wrong doesn't make B right. It really just comes back to the scientific method, and whatever we do and whatever we practice, whatever our profession, it should always be applied. And I think you're right. We need to have the bravery, if for want of a better word, to sometimes call these people out. Not because it's personal. It should never be personal. But because if we don't call them out, then it just continues. And how do we evolve and develop our understanding of these things if this kind of stuff flourishes?
Absolutely. Now, all the stuff we've discussed is incredibly clinically relevant, but for the sake of our physio listeners, we're going to rattle through a few questions that are going to be real take-home things that they can do differently in the clinic come Monday morning.
Okay.
All right. So, if you were to be prescribing an orthotic, should that be permanent for them, in your opinion?
It's a good point, and I think the analogy that was always used of sort of spectacles, glasses, this is something that corrects you, a word that I dislike immensely, because correct suggests we're shooting for something. It comes back to that normal paradigm, but historically these are like glasses. They correct you. You're going to need them for the rest of your life. Being given a pair of devices was a life sentence. I think that's probably not the case anymore, or it shouldn't be the case. It will be for some, of course. There's always going to be people that you feel are going to function better with some external help, but ultimately it's a difficult question because you've got to do it with the patient in front of you, the patient, the pathology. And what you're deciding is this tissue that's becoming overloaded from a mechanical perspective, the devices will alter its load in the short term. Do you feel that you can increase that tissue's load capacity in the long term so that device can then eventually be removed? So is this device just facilitating a more pain-free way of moving and offloading as part of the early stages of rehab that we can then remove later? And in some cases, it will absolutely be the case. In some cases, orthoses aren't even appropriate to start with. But I think just assuming because we see a foot posture and we give a device, you're going to need this for the rest of your life, I think that, again, is a bit old-fashioned. And again, the word correct, as I said, is just a terrible term. When we're giving devices, we're not, or certainly when I'm giving devices, I'm not shooting for a position. If someone comes in everted, and I feel that position is correlated with their pathology, rightly or wrongly, and I give them a device, I'm not necessarily trying to invert them. And if I was, I'm not necessarily trying to invert them to position A or B. I'm trying to introduce a change. And with my understanding of the tissue and the joint axes and joint moments and physics and all that nerdy stuff that I know we love as much as each other, I'm hopefully going to achieve that goal. Does that make sense?
It does, absolutely. And so it's individualized as much as everything else. And so the time frame in which someone has it is going to be in keeping with all the rest of the reasoning.
Yeah, I think so.
How customizable does a device therefore need to be, in your opinion? So it's the age-old customized versus off-the-shelf sort of debate.
Yeah. If you remove cost and durability from the equation, which are two factors that you need to discuss with the patient, because they may well influence their decision. If you're purely just looking at mechanism of action, and we kind of touched on earlier on how these devices have kinetic effects, or at least we believe that their kinetic effects are the most profound ones that are currently explaining their actions. Those kinetic effects, and I've written about this before, are dictated by the design features of the device. So its shape or its geometry, top surface topography, its stiffness, its load deformation characteristics, to name but two. So when you're comparing devices, whether it be different custom made or different off the shelf, or off the shelf versus custom made, I actually think they've got a lot more in common than not, because they all have these variables. And if you decide in your mind, again, rightly or wrongly, the geometry of the shell and the stiffness of the shell that you feel will deliver the best external force to that body, which will elicit a positive clinical outcome. If you can get those variables in an off-the-shelf device, and it's going to save the patient a lot of money, and you're going to get it quicker, maybe that's another factor, then great. If you feel that there's, with your knowledge of the market out there, there's nothing off the shelf that really is going to deliver the device that you visualize. And whenever I see someone, I'm visualizing what the device needs to look like. Then we're going to have to go custom made. Custom made essentially gives us a lot more control, an awful lot more control. We can ask for shells to be made of different materials, different stiffnesses. We can have different parts of the shell to be different stiffnesses to each other. Its geometry, whether it has an internal or external posting, all of these things are going to dictate the kinetic effects. So I think it really comes back to, rather than just should I give off the shelf or custom made, it comes back to understanding what these devices do, how they're designed dictates how they work, and then basing your decision of what you give on the way the device looks. Yeah, the off-the-shelf versus custom-made debate rages on, but like I say, it's not much of a debate. It's about you trying to deliver prescription variables to a patient.
It's what you're trying to achieve. That's the only thing that really needs to be debated.
That's the thought process. The crazy thing is, and it harks back to the beauty of the subtalar joint neutral model, is people saying, oh, do I need a 4-degree post on this or a 5-degree post on this? Well, if you're arguing over 1 degree on your prescription, as soon as that goes into a shoe, which may well have a bevel with inside it, as soon as then that person goes onto the pavement outside, which has a camber, or they walk up a hill or down a hill, the whole thing, why are we worrying about 1 degree? Because the reality is there's too many layers here where this thing is going to probably not matter quite so much. And Simon Spooner's written the best work in my regard on this, and he talks about the positive orthoses solution sets. So you present to me with problem A, there isn't one prescription that's going to get that better. This isn't you coming to the doctor for an antibiotic. There are a range of possible positive orthoses solution sets, or an envelope of success. So if someone gives you a 6-degree post and you get better, would you have got better with a 4, 5, or 7, 8? Maybe. You get the idea. Yeah. So we like to try and understand these things as much as we can from an academic perspective, scientific perspective. And we really do look into it in that much detail. But the reality is, in clinic, do we need to be that accurate? And the answer is probably not. So when we look at the studies that have shown that orthoses on average change rear foot kinematics by 2 to 3 degrees, and then we consider the environmental influences and different footwear that this device will move into, we start really thinking, wow, this probably isn't as kind of the requirement to be as super accurate with this prescription probably isn't necessary. Hence why you put something in someone's shoe and it may do something good. Back in the good old days when subtalar joint neutral was king, what you were taught to do was measure how everted or inverted, whatever it was, what the position of the rear foot was in degrees, and let's say it was 4 degrees, you were then taught to write if you're everted by 4 degrees, you invert the device by 4 degrees. And again, I long for those days back. It was a simpler time. There's no doubt. The reality now is, the horrible truth, and I'll just say it, is when you're writing a prescription, you just throw a number out there. And perhaps that's unfair. You base it on your experience.
Educated guess,
yeah, an educated guess. Your experience, your clinical reasoning, things that you feel have been successful for that type of issue previously. But ultimately, you're popping a number down on paper that you've pulled out the air based on these factors.
Yeah.
And you don't always get it right. Let's not pretend we always get this right, because we don't. And like we say, if we pop a number on the prescription and someone comes back and they don't feel that they're getting better. And remember, we're not reviewing them with respect to how vertical they are and saying this device isn't working, we need to tilt you up more and realign you. It's purely based on pain. It's purely based on symptomology. And if I feel that I need to modify that prescription because I've got it not as right as I could have done the first time, then we have to make those changes. And it does happen. I'm incredibly fortunate to have a great relationship with an orthoses lab who are called Firefly, who are based in Ireland. And right. Over the years, I've developed a great relationship with them, and they're incredibly accepting of what an unexact science it can be on the clinical level. So I'll often send devices back to them and badger them and say, look, can we change this? Can we change that? And they're fantastic at doing it. And you can often call them and sort of say, this is kind of what I want to deliver. Do we have a material that fits what I'm trying to deliver here? And they're constantly evolving and ultimately moving with the technology. these things will all be done by 3D printing one day.
Right.
They're already looking into that.
Wow.
Yeah. So
pretty forward thinking.
Yeah, absolutely. And the other thing, and it touches back on the sort of over-prescription of these devices that we talked about earlier, there are some labs that if you have a relationship with them, they will sort of demand you send them a certain amount of put-through.
Right.
I know that sounds unethical and ridiculous, but I promise you.
Really? That's out there, is it?
That's out there.
Okay.
Not the case with these guys. I mean, as you know me, hopefully you know me by now. That's not a lab I would associate myself with. No. So I just love the way that the lab I use practice, support me, and just help. Kind of ultimately, we're all there for the patient.
Help you help people. What they seem to be doing. So that's cool. No, that's really good. The last question, I guess, is there anything else or anyone else that you'd like to direct listeners to as we wrap up today? Yes, I mean, I kind of talk about my podiatry mentors. Some of them mentor. Well, my biggest mentor and very good friend is Dr. Simon Spooner. He's very old school. He's not particularly one for social media and things, but you can read some of his published work. The guy's a genius, as is Dr. Kevin Kirby, an absolute hero of mine. Craig Payne, who I know you're familiar with, and someone who I've always respected is Chris Nestor, who's published some phenomenal work on the mid-tarsal joint and on foot kinematics, bone pin studies. He, for me at least, has fundamentally published some of the work that's really challenged the way we think about the foot. So they're the four big names within podiatry. That podiatrists will know all four of those names, but maybe physiotherapists won't. Absolutely. So we'll provide some of those references for our listeners as part of our show notes. And perfect, because I'd love for people outside of podiatry to read these guys' work, because they're the shoulders that I stand on. For sure. And if people want to hear more from you, what's the best way to get in touch? I am a social media nerd. I love a bit of social media. So I mean, I'm on Twitter. People are more than happy to exchange with people on Twitter, or they can email me. I presume I can. We can definitely provide that. It's not a problem. Your Twitter handle being @sport_pod. @sports_pod. Yep, that's my Twitter handle. Obviously, I can give you my email address. I've got a very modest blog, but to be honest, I seldom update it. But I've written a bit of work for other blogs. Fantastic. No, thanks a lot for your time today. It's been great to have you on. Absolute pleasure. No, all the best then. Thanks, mate. And that was session 18. Huge thanks to Griff for his time and for sharing as much as he does across social media and beyond. I had a couple of extra questions on the tip of my tongue that we simply didn't have the time to flesh out, including a particularly awkward one regarding the fact that the tissue stress approach is seemingly assumptive that nociception is king when it comes to lower limb overuse injuries. So if you're interested in more on this topic and would like to pose your own questions to Griff as a follow-up to this, then get in touch with our podcast team on Facebook or Twitter, because me and Ian are planning a follow-up, maybe over Skype, once we get some feedback on this episode. So do let us know. Having spent some time in clinic with him recently, I've come to realise that as long as podiatrists work within their skill set and refer onwards where appropriate, if we refer the right patients, it maybe doesn't matter so much that the reasoning and interventions are predominantly founded in biomechanical principles. But of course, let us know if you disagree with that. Huge thanks to Firefly Orthoses, who's kindly sponsored this episode. I emailed their company founder and medical director, Martin, who's a podiatrist by trade, to ask if there was anything specifically that he'd like to promote. His reply wouldn't be done justice if I was to paraphrase it, so I'll quote, "Hi Jack, the key thing is that orthoses are not required for everyone, but if it's chosen by a professional following a full assessment as a conservative option, then I hope your listeners will consider Firefly." Now, I don't know about you guys, but that's the sort of company ethos that I'm proud to promote, and I hope you can all get behind it too. Visit firefly.ie or contact through the Choose Health Consultancy Framework for more details. But until next time, you've been listening to the Physio Matters podcast, discussing physio matters because physio matters. Bye for now.